Yeah, hi guys, hi everyone. We have an amazing doctor this debate. His name is Dr. Aadarsh. As well, he is a thyroid specialist as well, a breast surgeon as well, an endocrine surgeon as well. Doctor has been consulting in Patterson Cancer Institute at Parapalli as well as Helios Clinic as well. Hi, doctor. Nice. Hi, Mario. Good to see you. Now, how did your journey in with the whole doctor field started?
Right. So from 2012, I graduated from my MBBS and about 12, 13 years of experience. Did my master's in general surgery and then my super specialization in endocrine and breast surgery as well. So here we are right now.
So, the invasive part, surgeon becoming a surgeon, how what was that change? When did you take this?
Right.
I want to be a surgeon.
Good, good. So initially during MBBS, we have thoughts of specializing into various departments. You'll get exposed to every field. So in that, surgery fascinated me the most near the fag end of my MBBS. During the period of training, we called it as internship there. So at that point, I thought I want to be a surgeon and then started working towards getting a master's in general surgery, which eventually happened. And here I am now. Yeah,
That's great. We will talk more about your specialization. We'll probably start the word thyroid
yeah,
in general. Like it does scare people, and it does often come common in women as well than in men.
right.
The starting of thyroid. How does this happen in one's body?
Right. So the most common things that people are aware of or are scared of is just a thyroid disorder per se. So me being a thyroid surgeon, so what I will say is if there is any swelling in the neck that you see, it's always better to address it. You do go to a nearby doctor, ask them to have it examined. If required, you could do a scan, say an ultrasound scan should be enough, and we'll see what it is. It could be a thyroid swelling after all. We have to see what it is and then you take it forward from that. But in general, what public fear will be more of a thyroid disorder that can be either a hypothyroidism or a hyperthyroidism, where the thyroid functions less or functions more than what is required by the body at that point in time. And that is something that we need to look into. That will be taken care of usually by the medical endocrinologists.
Thyroid, does it affect like to the stress or modern lifestyle right now in these days? At which occurs this problem of thyroid?
Okay, so in the thyroid problem that you are talking about will be the thyroid disorders per se. And does stress play a role? Definitely, there is a role for stress in this. Modern lifestyle and the alterations of your sleep-wake cycle, when the sleep is not adequate or when you have night shifts and all that is going to have a disturbance in something that we call as the rhythm of the body, the sleep-wake cycle rhythm of the body, and that is going to affect not just the thyroid, but various endocrine organs are being affected with that. So it is something that we need to address, and we need to adjust accordingly as well. And a healthy lifestyle with adequate exercise and proper nutrition will help curb all this. It cannot be an absolute no, because modern lifestyle, the income, everything matters. There's a lot of parameters that we have to keep in mind before we say don't do this, don't do that. But yes, we'll try to keep it as simple as possible. We'll keep the hormonal system under control.
Why does this often come on more in women than in men? Is that
Women are more subjected to hormonal fluctuations, and their other hormones also have an impact on the thyroid, which is slightly lesser in the male. And that's the only reason why it is more common in women than in men. Yeah.
the undiagnosed part, like is like a woman has it? How does she, like in the initial stage, we say swelling is one.
Yeah.
Is there any discomforts in beforehand that they have to get to a doctor for a checkup?
Right. So I'll answer this from a surgeon's point of view, where I'm not going to deal with the hypothyroid or hyperthyroid part alone. I'm dealing with the swelling that you're asking. So initially, when she sees her face in the mirror, or it's usually when someone opposite, like I'm sitting here, I see your neck, I find some sort of a fullness there. That's usually the way the swelling in the neck is picked, where they either find a discomfort when they are taking bath or applying a jewel, or they don't look good in their photos. That's how it usually is, or it's by the bystander or the one who's standing opposite who finds it out. With thyroid, the swelling will be the most common presentations that we see for most disorders. If it is associated with, say, a hyperthyroidism or a hypothyroidism, The swellings can be of varying sizes and shapes and have associated factors of them that we need to look at.
There's even more something in thyroid which is more complex. So, cancer.
Oh, right.
Thyroid.
Cancer in thyroid, it is being in an increasing trend, probably because there is more picking up of these nodules by more number of ultrasounds that are happening nowadays. But luckily, thyroid malignancy has a stable course. It's not something that is extremely fearful that for the public. So what we can think of is there are every cancer of every organ has various types. It's not that there's going to be only one type of cancer that's going to occur in one organ or one gland. Likewise, in thyroid also you have some cancers, some different types of cancers, and each have their own prognostic values. There are some that are very rapid, there are some that are very indolent. Luckily, most cancers in thyroid are indolent. So there's nothing too worrisome when you are initially diagnosed with the malignancy. Always it matters on the type of malignancy and how far it has gone. Treatment options are available for most of them.
Is there any link between pollution and dietary habits has increased this rate of thyroid or cancer in thyroid?
Cancer in thyroid.
Cancer in general.
So there is
What like the urbanization does play a role?
not really. Why? Because if you take family history into consideration, and if you take something called as radiation exposure in childhood, these are the two things that you are able to relate to for the development of malignancy of the thyroid. Other than that, it's predominantly, we call it as de novo. We actually don't know the exact reason as to why this particular event has happened in the thyroid. That's the only reason. We don't have enough data to say that it's actually the air pollution that has caused this, that this lifestyle change has caused this for a cancer per se. Yes.
As you said, there's something called the beta gland, the medullary side, and genetics play a role. No? Like in India, genetics are more complex as well, and we are more prone to diseases because of our genetics. Why is that? Is there a fault which happened like 50 years back, or is the lifestyle rapidly changing and we're developing a lot of genetic disorders?
So that's too vague a statement to make that in India we are having a lot of genetic disorders and all that. Because till now, the West has the most things because they do the genetic studies. We have a larger population base, so it might not be possible to do a genetic study in every individual or every child that is born. And one more thing is, I don't know if I can call this as because of our genetic predilection that all this is happening. I don't think that will be a right statement to make. So what I will think is the incidence is increasing because you're able to pick it up early. That's what I will think of it as.
Pick it up early, do you mean like?
Yeah, the malignancy, you can pick the malignancy when it is small. You can pick the malignancy when it is spread. So the earlier you diagnose any condition for that matter, forget it being malignancy or otherwise, the earlier you pick it up, the more chances that you have to bring yourself back to normal soon. So that's how I look at it as.
Perhaps the screening part of thyroid. See, the youngsters are now these days are much prone to cancer, and because of life stages, we've seen cases as well. Okay, in childhood, like adults and non-adolescent age are facing these problems.
Right.
Is there something that they have to do in order, like in change of habits or lifestyle? Is there something that we have to be considered on? Give measures taken to avoid to this state.
Okay. So if the discussion is on increased incidence of cancer, the answer is I will not relate it to any of the lifestyle changes that we are having, because cancer per se is seen more commonly in the adults with thyroids, or it can be seen in the younger age group where it can be kids, it can be newborns, or not exactly newborns, but in the infancy period also, but those are genetically predisposed malignancies. In the younger age group, yes, with less than 20 years of age, the malignancy do occur. The malignancies that occur in thyroid in this childhood period that we are talking about, less than 20 years of age, are usually more aggressive, but they respond well to treatment. So is there any particular way with which you can prevent this? The answer might not be there yet. Is there, because we are yet to delay with this exactly is the cause why this has occurred in childhood. That will be very difficult unless, other than the two things that I told you, there should be some family history or some radiation exposure. The radiation exposure again is more medical, where you would have given treatment for some other malignancies that were existing in the body. You can give radiation therapy to the neck for some reason, or they should have been exposed to some radio blasts, like what has happened in Japan and all that. So where they have been exposed to a nuclear bomb attack, and they carry that in their genetic system and so on.
I'm taking out
Yeah.
from your answer. I'm taking out one question. Does this parents cry where a 15-year-old, what did they do? Like they didn't put to drink alcohol, they didn't respect their habits. But why? But why is this? Why cancer? Why like for a 15-year-old? How does it develop like your children?
Okay, so that will be more medical and more complex to answer. So what we can think of is there is increase and decrease in size of any part of the body. There will be some multiplication of cells that is happening, and there is a control system that we have to say if there is a bad cell that's produced, the body says this is bad and this is out. Something like probably the advertisement that we see on TV, where the Ghana cocoa is taken and one small guy, no, I don't want to use him, like that. So the body says that, no, I don't want to use this for further development because it's a defectively metabolizing cell. This is our body's defense mechanism. So when there is something that deranges in this, can be at one cell level at any point in time, that can multiply eventually to become a cancer. He becomes the rugged guy. He does not listen to your system.
No.
He somehow found a way to bypass your system. And the bad guy, the system didn't detect me. It's like an aberration, and that aberration slowly develops. He is not being controlled by the bodily system because it's not able to detect that as an aberration, and that can become a malignancy. So is there anything, and coming to the emotional point of your question, why me or why him or whoever that might be, that will be very difficult to answer at this point in time. Now what we have to do is it has come, but to treat that, and if it is genetic, if there is a family history, if there is a predisposition, then there is something that you can do in the sibling or the subsequent generation. That's how you take it forward, instead of going one step back, saying why me.
As like when you said in families, we have some family member who has cancer and have gone surgery and things have gone bad. In the family members, what are the protocols they have to take, like in the near future, like an adrenal and better than test?
Right, right. So if there is a family history of thyroid malignancy, then some thyroid malignancies are associated with other malignancies as well. That's fine. Or other lesions as well. They need not be malignancies, but they can be swellings or masses elsewhere. That can occur. Like some can be associated with the breast, some can be associated with the adrenal glands and all that. So what we can do is, if they are found to be genetically predisposed, then we have screening protocols for them, which we will recommend for them. If there are some familial syndromes that are occurring, then they have specific screening protocols that we'll recommend. So we'll tell them to do periodically some blood test or some investigation. Say for example, I'll give you an example of none of these syndromes are associated, but just a thyroid malignancy you have seen in one person. Say in the parrot. So is the child prone? Maybe yes. If the child has some problem, then we will recommend an ultrasound. Ultrasound is more or less a cheap, no ionizing radiation in that. We can do an ultrasound of the neck and look for any nodules. The malignancy usually presents with a nodule that might not be visible, but there can be a subtle change. As I told you, it begins very subtle. There can be a subtle change inside that probably we can pick with an ultrasound, and we grade that nodule, and then we see whether there is a risk or not. You do a test on that, and then you proceed. That's how we take it forward. But again, so in the family, it is not mandatory that if the father or mother has had it, the son or daughter should have it. It is not mandatory. It's just that slightly more prone. That's about it.
Something called lymph nodes.
Yeah.
Like from the, I don't know speaking, the medically, are they host? Are they a host for cancers? Or
Oh, no. They are technically your defense.
okay.
So they are defense. As I told you, so when the cell cycle is happening and I am not able to stop it at that level, then there is a cancer that's formed and that guy is going to spread. So when I'm spreading, I need to put barricades at different levels. My first level barricade is the gland's own capsule. The second barricade is going to be the adjacent lymph node. So when you pick it up at the lymph node level, which means it is spread technically beyond your gland somehow. It is seeped out.
Okay.
From there, it seeps to further places. I'm speaking all in terms of thyroid. It's not general malignancies, but in thyroid. So in thyroid malignancy, you have a thyroid mass, and that is spread to the lymph node. From there, it can spread depending on what type of cancer it is to the bone or the brain or the lung, depending on wherever it can potentially go. But the lymph nodes are your guardians. You need them. They are increasing in size like, how do I say this? So you can imagine it as I am 1 centimeter in size, but the cancer that is in the one I'm going to stop is larger. So I have to increase in size to keep you under control types. So technically your guardians, you have lymph nodes in your body everywhere. So you have about 800 lymph nodes in the body, but you don't see them anywhere. When you see them, they are actually enlarging to keep you protected. So, and they harbor the disease for you. I agree. They harbor the disease for you.
So lymph nodes going unnoticed is a problem.
Yeah, it should not be unnoticed. That's the point I'm coming to. So in case the type of cancer spreads through lymph nodes. There are some cancers that spread through blood only. So there's those that spread through the lymph node. The lymph node going unnoticed will be a very rarity, because they will enlarge. They have become the next basin for the malignancy. So it's like I'm done with the thyroid, or technically I'm there in the thyroid. I want one more place. We are buying a new apartment. So I go there to the lymph node.
So this transaction happens to
Yes.
suppressed lungs, like something that even from small to elderly people have to be conserved.
True.
And import this, and it is probably a stigma still going on, like the breast examination, or if there's something in your breast, there may be a fatty component, or maybe something that's not has to be
Exactly.
a road of,
So a breast lump per se. So the breast can have lumps as a bodily change. All right, fair enough. So is a bodily change that can occur. There are some developmental changes that occur in the breast. The breast develops from the breast bud, increases in size, has its own reproductive function where lactate-3 functions are going to be there. So the hormonal changes during pregnancy is going to have its effect on the breast as well. So all that is going to have some normal development of the breast, and there is something called as involution that eventually happens. As the woman ends her reproductive phase, this is going to end. As she attains menopause or is nearing towards that, some changes are going to occur. So, எல்லா breast கட்டியுமே கேன்சர் தானா அப்படின்னா கிடையவே கிடையாது. கேன்சர் கட்டி கம்மியான சான்சஸ் தான். கேன்சர் உலகத்தில் பார்த்தீங்கன்னா 50-60 வயசில் அதிகமாக பார்க்குறோம் பிரெஸ்ட்டு. இந்தியா பொறுத்த வரைக்கும் ஒரு டிகேட் ஏர்லியர்னு சொல்லுவோம். 40-50 வயசுக்குள்ளே கொஞ்சம் அதிகமாக இன்சிடென்ஸ் இருக்குது. அதாவது அந்த ஏஜ்லேருந்தே நம்ம பார்க்க ஆரம்பிக்கிறது பெட்டர் அப்படின்ற பாயிண்டில் நம்ம இருக்கோம். அது கேன்சர் கட்டியை பொறுத்த வரைக்கும். பிரெஸ்ட்டை பொறுத்த வரைக்கும் நீங்கள் பார்த்தீங்கன்னா அவங்க என்னென்ன தொந்தரவோட வரலான்னா, ஒன்று கட்டி, இன்னொன்று நிப்பிள் டிஸ்சார்ஜ், நிப்பிள்லேருந்து டிஸ்சார்ஜ், அதெல்லாம் பினியன் கண்டிஷன்ஸில் கூட வரும். அது கேன்சராக இருக்கணுன்ற அவசியமே கிடையாது. ஒரு ப்ராப்பர் ஸ்க்ரீனிங் நம்ம அதுக்கு பண்ணிட்டோம்னாலே போதுமானது, பிரச்சனை.
So what are the the intervals for a person to come and do a checkup, take care of the breast in general?
Sure.
How does that process?
Okay, so and the year process is a much later phenomenon. Earlier நம்ம என்ன ஆரம்பிக்கலாம் அப்படின்னா செல்ஃப் பிரெஸ்ட் எக்ஸாமினேஷன் ஒன்று ஆரம்பிட்டோம். அப்போ என்னென்னா we educate ideally ஸ்கூல் சில்ட்ரன் காலேஜ் கோயிங்லேயே நம்ம அதை எஜுகேட் பண்ண ஆரம்பிச்சிட்டோம்னா, once they reach their 25 age, அந்த டைமில் they can start doing a self breast examination. ஸோ அவங்களே கண்ணாடி முன்னாடி போய் நின்றுட்டு இந்த மாதிரி அந்த மாதிரி எப்படி இருக்குதுன்னு பார்த்துட்டு ஃபுல் பிரெஸ்ட்டை அவங்களே பால்பேட் பண்ணி பார்க்கலாம், தொட்டு பார்த்துக்கலாம். இதான் டிஃப்ரெண்ட்டாக தெரியாது. இதை மாதத்துக்கு ஒரு தடவை பண்ணிட்டா போதும். இதுவே ஒரு நல்ல பேசிக் வேலை வீட்டில் பண்ணுறதுக்கு. எனக்கு நான் சொன்ன மாதிரியே தான் பிரெஸ்ட்டை பொறுத்த வரைக்கும் அந்த கட்டி அவ்வளோ பெரிய மாரில் உள்ளே கட்டி வர்றது வெளியே தெரியணுன்ற அவசியமே கிடையாது. அது இங்கே தொட்டு பார்த்தா தான் தெரிய போகுது. ஒரு தைராய்டாவது ஆப்வியஸாக நீங்கள் பார்த்துருவீங்க, அது அப்படியே இருக்கணும். அதுவுமே நான் சொன்ன மாதிரி ஆப்வியஸ் சட்டிலாக கூட வரலாம், சின்ன நாடியூலாக கூட தான் ஆரம்பிக்கும். இது எப்போவுமே வெளியே தெரியணுன்ற அவசியமே கிடையாது. அதே மாதிரி தான் பிரெஸ்ட்டுக்கும். ஸோ யூ கேன் do a self breast examination every month. You find anything abnormal, அந்த ஏஜுக்கு ஏற்ற மாதிரி பிரஸ்ட்டுக்கு ஏற்ற மாதிரி வீல் சஜஸ்ட் இந்த இன்வெஸ்டிகேஷன் பண்ணுங்கள் அந்த இன்வெஸ்டிகேஷன் பண்ணுங்கன்னு சொல்லிட்டு ஒரு பேசிக் ஸ்க்ரீனிங் மாதிரி கூட நம்ம பண்ணிக்கலாம்.
That is for like 25 and above.
Yeah.
For women like who are reaching the mid-30s and not,
Okay.
do they have to go like to the hospital to get the self-examination, or it's like possible?
Beautiful. So what you do at home is the self breast examination. What you do at the hospital is a clinical breast examination where you're having an expert to do it for you. It can be a trained staff nurse as in the Western world, or here the doctor themselves do it. So you examine the breast in various positions and you see that there's nothing there. You ideally, in a younger age group, you might suggest an ultrasound of the breast. If they are more than 40, 45 years, there's more of fiber fatty tissue only, not much of glandular tissue in them. As I told you, as age is going, you can do a mammography as well. X-ray mammography as well can be done. So that way it is more comprehensive. You don't miss the smaller lesions. That's the reason.
So advisedly, like you say, for clinical examination, yearly ones?
Yeah, yearly once is recommended. You can do a screening mammography from the age of even 40 years of age. You can do it once a year from 40 years of age. That should be good. And the report should be read by a proper radiologist. And if that can be done and the breast surgeon is there, that should be more than enough.
From the surgeon,
Yeah.
I would like you to give us like probably break the stigma of women not having their fear of going to a doctor to check their breast or like do a clinical examination. Can you break that stigma or give them a pop of advice? Like it is not, you shouldn't worry about it. It's not some risk carrying. It's like
Correct.
totally like normally getting up and brushing your teeth. This is something that has to be done.
Correct. Once a year. That's about it. So when it is a screening or just an examination that we are going to do, just once a year should suffice, or whenever you feel a discomfort. You are actually thinking there's actually something not right. I did a self-breast examination, but I'm not happy with what I found. I think there's something abnormal compared to last month. If that's the case, then it is always better to consult a nearby doctor or a nearby staff nurse and let the medical professional do the examination. That's one thing. With stigma, that's logical. That's how we are. We are a conservative society. So what I will recommend is, if this can be done as a routine, when it is something abnormal, the problem is with most of us, it is more of the peer pressure that we have. What will they think? That is something that we need to be getting out of our minds. It is okay. It is immaterial of what you think about me, because it's my health. My health is my priority. If that is kept in mind, then all this can be overcome easily.
That's something that there. So there are stages, doctor, because you said like in Tesla, so yeah, like you're seeing cases of, you are seeing cases, I personally seen cases.
Yeah.
We will fourth stage also, they have come over.
Right?
So the stages of difference, the scarcity or the life expectancy, breast cancer is treated. Yeah, it is treated.
Yeah.
And there are two cancers, thyroid and breast is much more treated.
Yeah, very much, very much. I wish I can generalize as easily as you did, but yes, definitely. Thyroid and breast cancer, like most cancers in the body, are actually treatable.
Okay.
That's why we exist. And that's what we exist for. We have to treat it. It is possible. So it's not that the surgeon alone is going to treat it. There'll be multimodality treatments that you can have. But definitely, all malignancies are treatable. Just that, at what point you come, what is the tumor biology? As I told you, not every cancer is this. It's not cancer. It is this type of cancer, that type of, there's a cellular biology that happens, and you have to target that accordingly. So the treatment options that you give to the patient will be based on that. And with that basis, we can tell how much the recovery is going to be, how long it is going to take, and all that. You plan it like that. So coming back to your question on breast and the staging. So with stage 1, stage 2, stage 3, stage 4 is what everyone commonly uses. They say 4th stage, last stage, nothing can be done. All this is from either cinemas or from the neighbor and not from the doctor. So that's very important for us to remember. Okay. So the thing is, it can be even a stage 4 malignancy that is immaterial. It can be like, for example, there can be a metastatic malignancy. It is spread to some place. But if the tumor biology is a good one, you have only picked it late, then you can be cured. Why does the cinema not say that? Because they say they have only 2 hours to say all this, but we have 20 years still to live. Why leave that? That's the point. So early detection is always key, but come what may, wherever you stand, if there is a potential for cure, you should give it. Instead of saying, okay, leave it, let them succumb to the disease. That's very rarely done to any malignancy per se. Yes.
From the surgeon's from your perspective
Yeah.
of the surgeon, like cancer grows, we don't know how it grows and all that. Like we come to either the second stage or the third stage on the way to the top.
Right.
The first stage and second stage.
Mhm.
How does one know
Exactly.
their body is abnormal or like any symptoms that your body gives out?
Right?
Is that
So you're in stage 1, say for example. Stage 1 for most malignancies is going to be confined to that particular gland or organ. You're speaking about breast. Breast is going to be, there is going to be some lump within the breast. How do you pick this? By your self-breast examination, or do you find anything abnormal? No. You do a clinical breast examination, do you find anything abnormal? No. You do a radiological assessment with an ultrasound or a mammogram, depending on the age category that you fit into. Do you find anything abnormal? If it is stage 1, I would have picked something at this point in time. Now, how will I confirm that? I'll do a tissue diagnosis from it. Yeah, biopsy should be done. If this is done, so I have done clinical, I have done radiological, I have done pathological. When these 3 are there, picking up a malignancy in a breast lump, the sensitivity of what I'm talking about is about 99%. So now tell me, is this early detection possible? The answer will be yes. Just the willingness to have yourself examined or subjected to an investigation is the key. So if you're doing that as a routine, then I don't think you'll be picking up all these stage 4 cancers only at the time of presentation. You'll pick them up at stage 1 or stage 2 as well.
You think for women in general, the self-esteem breaks down?
With the diagnosis of malignancy, with someone says, yeah, I've been diagnosed with breast cancer, probably yes. But yeah, exactly. So that's the thought process. So you are the general public's viewpoint now. So is every cancer breast requiring a removal of the entire breast? The answer is no. So we as oncoplastic breast surgeons as well, we do something called as removal of the breast with adequate margins, and we can try to reconstruct the breast with surrounding tissues and maintain the breast as well. That is, and is that a complete treatment? Oncologically, is it complete? Yes. You have to give further treatment, like radiotherapy might be required, you might have chemotherapy required. The further treatments of the malignancy should be done. But you can still maintain the breast or maintain most of the breast, and you maintain the mound by the contour by autologous tissue from somewhere else. All this is possible. So it is not that if you have a CA breast, I have to remove it. So that's, I think, something the people should know. When you come at a point where there is not so much of tumor in your breast, that if I remove that, I have to give a normal clearance around it. So if I am not able to do all that, then probably, yes, I'll have to remove the breast. Even then, you can reconstruct it with some other tissue. You can take your tummy fat, put it back and all that. All that is possible. But that's a more complex thing. But when it's, as we said, a very tiny one, then I don't have to remove the entire breast for a tiny mass. I can just go, remove the mass and some surrounding tissue, and do an oncoplastic breast surgery, keep the breast intact and come out. So that's something that if people are aware, then in screening itself, if we pick more, we'll just have to remove a small amount of tissue. It'll be like as good as norm.
28 years to 35 years, yeah. And yes, one has a family and just got married. From that perspective, okay, that's just the best things that will not talk.
Yeah.
Can they have a family of their own after they are cancer free? Is that
Absolutely.
treatment that she can give them?
Absolutely. That is possible. It is not, it's a question of, them not having a family or having a family. All that is not going to be an issue when they have a carcinoma of the breast. That's not something they need to worry about. We have options, treatment options for that, where you can preserve your ovum, complete your chemotherapy and utilize that ovum. But once your cycle is back, you can plan for your pregnancy as well. That's okay. There will be very few rare instances where they are actually having genetic mutations. So we tell them, even if you have a kid, of course you can have a kid. You don't have malignancy right now. You have a potential to develop malignancy. The same can be in your child as well. This is what we tell them. That's about it.
But the feeding perspective?
Not really. So if, exactly, as I told you, if I am knocking the breast out, if that's your question, okay. I have knocked the breast out. Okay. So there is one more breast remaining.
Okay.
If that's what we are speaking about, they can feed in that breast. That's not an issue. It's not going to be complex at all. It's not going to be complex at all. The opposite breast is your normal breast, right? Your entire physiological processes of lactation is going to happen through that. So that is completely fine. I don't think that's anything you need to worry about.
That's great. Parathyroid tumors.
Yeah. So that's, we are coming to the endocrine part now. So the parathyroid and the adrenals. Yes. Yeah.
It's less known these days. And what is your take? Like, what do people have to know about that?
Okay. So parathyroids are, as the name suggests, parathyroids. So they're near the thyroid. So we see them and preserve them in all our thyroid surgeries. You don't knock them off because they're very, very, very essential for the bone strength. They maintain the calcium in your body. So they are extremely essential for your bones. So the calcium main store is your bone, right? So they are extremely essential. So the parathyroid tumors per se are, again, when they are not running in the family, they are usually a disease of the old, 50, 60 years of age, where they have a lesion here and that gets picked. And it rarely gets picked also. As you said, it's lesser known. So the mind does not see what, the eye does not see what the mind does not know. So it rarely gets picked. So the patient can have some tiredness, fatigue. You'll relate all that to old age. Anyway, you're 60, you're going to be tired. You're going to be having joint pains here and there. So those patients can have joint pains. They can have tiredness. Like, I want to get up from this chair, but I'm like, oh no, I'm feeling difficulty in my back or the hip. Your slowing down of movements can occur. There can be some constipation. There can be, its complications can also be there. How do you pick this? It's usually the calciums are raised. Where you do a routine blood test, your calcium levels are raised. Yeah, the parathyroid hormone is over-functioning. So it says, I want more calcium. So it removes all the calcium from the bone and keeps it in the blood. So that's when you develop these weaknesses, and that's why you're fatigued. That's why your joints are painful. That's why you're having a lower backache and all that. So the calcium levels are high, then you have a suspicion of it could be a hyperparathyroidism. That's what we call this. And then you investigate, like as I told you with anything in the neck, the first one is you do is an ultrasound of the neck. You look for any abnormal swellings there you can find. And then you diagnose it as hyperparathyroidism with your parathyroid hormone levels. And then you take a decision on surgical management. But the thing, as I told you before, with the topics that we have discussed, these are things that you have to address surgically. This hyperparathyroidism requires surgical intervention when it is having a lesion and that is causing this.
What are the surgical options for available for treating that?
Correct. So you can do routine neck surgeries. Like you would have been seeing people with a very tiny, thin skin line scar. You can go in and remove the parathyroid. Similarly, the thyroid also can be done through that. Then you have other remote approaches where you can do it with the scarless techniques, with which you can use natural orifices. Like you can go through the mouth, oral cavity, you can go through and get it out. Or you can go through the breast, you can go through the axilla as well, so that the scar is hidden. If people are not very keen on having a scar in the neck, then you can do it that way as well. Of course, they'll have their own pros and cons. The best time-tested way is the routine neck way.
Because I spoke to a lot of doctors.
Yeah.
An open surgery is far more better than any of the...
Yeah, it's it. So that's the time-tested one. And that gives you the utmost clearance that you can even think of. So that will be always the go-to option. And it'll be the best option as well. It might remain the best option as well, even with the time.
So would you say that keyhole surgeries, like bypassing and without scar,
All that.
you can advise them and tell them it's far more better to have an open surgery because you know
Agreed.
exactly what happens.
Exactly. That's one thing. The keyhole surgeries are more of a cosmetic reason for which you're doing it. Other than that, the exposure or, the amount of space that you have? Like, as a surgeon, I want space to operate.
Yeah.
Yeah. So that is best. Yeah, that is best when it is done through here, and the scar will, be on your skin crease. It's like I bend my neck. You won't know that there is a scar at all. It will be on your skin crease. So the natural folds of your skin, it will be the neck. It'll just be with that. It'll just be with that. So that's
Any surgeries that you would like to share, or any miraculous surgeries?
I don't know if I can call it miraculous, because we are expecting that surgery to bring about some sort of a recovery in them. So parathyroid is very tricky. So we can discuss that, because there will be some patient who will be crippled when they come to you because they would have seen it very late. நீங்கள் உள்ளே போயிட்டு அதுதான் பேராதைராய்டுன்னு நீங்கள் ப்ரீ ஆப்ரேட்டிவாக கண்டுபிடிச்சிட்டிங்க. இது பேராதைராய்டு தான், இதை போய் ரிமூவ் பண்ணிட்டா உங்களுக்கு ஓகே அப்படின்னு ஒரு ஃபீலிங் உங்களுக்கு புரிஞ்செடுத்து உள்ளே போய்ட்டு ஆப்ரேஷன் பண்ணி இந்த பேராதைராய்டு எடுத்துகிட்டு வந்துட்டோம். In 3 months, that patient will come back walking to you, thanking you. That's a possibility as well. Of course, all this is not in every case. If they don't have a fracture and all that, this is definitely possible. In some situations, எப்படின்னா அவங்களுக்கு ஃப்ராக்சர் ஆகிருக்கும். அந்த ஃப்ராக்சர் ஆனதுக்கப்புறம் தான் கால்சியம் லெவல்ஸ் அவங்க பார்த்துருப்பாங்களே. பிகாஸ் as I told you, இங்கே ஸ்க்ரீனிங்கிறது அவ்வளோ காமன் கிடையாது. We don't screen for every disorder in our body, any maybe the field, not just thyroid, breast or endocrine per se. நம்ம எதுக்கு ஸ்க்ரீனிங்லாம் பண்ணுறது ரொம்ப இன் வோக் கிடையாது அட்லீஸ்ட். ஸோ யூ ஹேவ் அ ஃப்ராக்சர். அப்போ ஃப்ராக்சர் ஆனதப்போ எலும்பு எவ்வளோ ஸ்ட்ரென்த்தாக இருக்குன்னு பார்க்கறது ஒரு கால்சியம் பார்ப்போம். அப்போ கால்சியம் இஸ் say 12, that's more than the normal. Then you think of, oh, this is hypercalcemia. Then this fracture could be not an accident-related fracture. It could be because the bone is weak. Otherwise, this same accident or the same trip and fall would not have caused this fracture if the bone was stronger. அப்போ பார்த்தீங்கன்னா the parathyroid hormone levels பார்த்துருப்பீங்க, it will be high. So once you correct that by surgery again, surgical intervention பண்ணி முடிக்கிறோம், அந்த டியூமரை நம்ம வெளியில் எடுத்துட்டோம். Now the body will develop its own way to come back to its normalcy. அது வந்ததுக்கப்புறம் we have 4 parathyroids, luckily. So you have the others that can compensate over time and maintain this calcium levels in the body. So once that is done, நீங்கள் பார்த்தீங்கன்னா the bone will slowly start gaining strength. Now this patient will come back to you in walking. Oh, that's something that you can be very happy about. The gratification, yeah.
Please.
Yeah, the gratification that we get once you've done something like that, it's probably something. Miracle, I think we have to leave it with God.
It's sometimes not necessary to be parathyroid, like bone weakenings or fracture.
Well,
We can pulse TV also in bones as well.
agreed. Very good.
So it's not necessary, should be
Exactly. So every bone weakness is parathyroid related. அப்படின்னு நம்மளால் சொல்லவே முடியாது. ஆனால் போன் ஒரு ஸ்ட்ரென்த்துக்கு இந்த பேராதைராய்டு விட்டமின் டி லெவல்ஸ் எல்லாம் கரெக்டான அவங்க வேலையை பார்த்துட்டு இருந்தால் தான் கரெக்டாக இருக்கும். அதுதான் ஃபேக்ட். There are other hormonal reasons for that. There will be too much to discuss right now. But என்னென்னா, you have a bone weakness. அதாவது நம்ம ஆஸ்டியோபோரோசிஸ்ன்ற வார்த்தை நிறைய இடத்துல பார்க்குறோம். ஆல் அவர் அட்வர்டைஸ்மெண்ட்ஸ் ஆர் ஆல்சோ ரீடிங் ஆஸ்டியோபோரோசிஸ். இதுதான் உங்கள் ஸ்ட்ரென்த் இதுன்னு சொல்லிட்டு. தட் இஸ் அ ஏஜ் ரிலேட்டட் திங் தட் ஹேப்பன்ஸ். அகெயின் அது ஹார்மோன்ஸ் இல்லது மேலே இருக்கலாம், கீழே இருக்கலாம். அகெயின் நீங்கள் அதை பார்த்தீங்கன்னா ஸ்லைட்லி மோர் காமன் இன் விமன்னு சொல்கிறோம். பிகாஸ் த போன் ஸ்ட்ரென்த் இஸ் ஈஸ்ட்ரஜன் டிபெண்ட். விமன் என்டையர் மெட்டபாலிசம் இஸ் ஈஸ்ட்ரஜன் டிபெண்ட். ஸோ நீங்கள் அது மெனோபாஸ்க்கு அப்புறம் பார்த்தீங்கன்னா உடம்புல ஈஸ்ட்ரஜன் வரலை. ஸோ அவங்களுக்கு அந்த போனுக்கான தேவை ஆனால் ஈஸ்ட்ரஜன் கிடைக்கல. ஸோ போன் ஸ்லைட்டாக வீக்காக இருக்குது. அவ்வளோதான், அப்படி தான் பார்க்கணும். அதான் நீங்கள் போன் மினரல் டென்சிட்டி நீங்கள் சொல்கிறது அதுதான். ஸோ போன் மினரல் டென்சிட்டி நம்ம பார்த்துட்டோம்னா அதில் நம்ம சில கேட்டகரைசேஷன்ஸ் வச்சுருக்கோம். நார்மலாக இருக்கா, கொஞ்சம் வீக்காக இருக்கா, ரொம்ப வீக்காக இருக்கா, இல்லை ஃப்ராக்சரோடையே இருக்கா அப்படின்னு சொல்லிட்டு நம்ம பார்த்துருவோம். அதை பார்த்துட்டு வில் தேக்கக்கோ இது எல்லாத்துக்குமே காரணம் பேராதைராய்டு தான்னு கேட்டிங்கன்னா, அந்த மேலே ஒருத்தர் இருக்கான் அவன் எல்லாத்தையும் பார்த்து அப்படி வராது. பட் there can be various causes to this. There can be just a simple vitamin D deficiency that has caused all this. நீங்கள் அதை கரெக்ட் பண்ணிட்டீங்கன்னா இது எல்லாமே சரியாக போய்டுன்னு சொன்னால் யாருமே ஒத்துக்க மாட்டாங்க. நீங்கள் ஃப்ராக்சரோடு வந்திருக்கேன், போன்லாம் இங்கே செஸ்டெல்லாம் அப்படியே வீங்கி போய் வந்திருக்கேன், ஆனால் நீங்கள் வெறும் ஒரே ஒரு மாத்திரை கொடுக்குறீங்க அப்படின்ற அந்த எண்ணம் வரும். பட் இட்ஸ் ஜஸ்ட் அ வைட்டமின் டி டெஃபிஷியன்சி தட்ஸ் பின் க்ரானிக். அதை நீங்கள் ட்ரீட் பண்ணிட்டா சரியாக போய்ட்டோம்னா அதை பண்ணிடலாமே. ஸோ இந்த மெட்டபாலிசம் மெக்கானிசம்குள்ளே எவனா ஒரு காசாக இருக்கலாம். விட்டமின் டியாக இருக்கலாம், பேராதைராய்டாக இருக்கலாம், இல்லை கால்சியமாக இருக்கலாம், அதர் ஹார்மோன்ஸ் அதுவாக இருக்கும். ஸோ இது எல்லாத்துக்குமே ஒன்று தான் சொல்கிறது கஷ்டம்.
The common test should be taken after scale roll.
ஓகே சூப்பர். ஸோ நீங்கள் என்ன பார்க்கலாம்னா பேசிக் இஸ் த சீரம் கால்சியம் லெவல்ஸ், வைட்டமின் டி லெவல்ஸ். இது ரெண்டுமே நம்ம பார்த்துறது நமக்கு ஒரு ஐடியா கிடச்சி. சரிங்களா? அதுலேயும் கால்சியம் முக்கியமாக இந்த பாராதைராய்டிசமை கண்டுபிடிக்கணும். கால்சியம் பார்த்தா கால்சியம் அதிகமாக இருக்குது அப்படின்னா அப்போ பாராதைராய்டு அதிகமாக இருக்கோ அப்படின்னு ஒரு டவுட் அதுக்கப்புறம் தான் வரணும். இட் இஸ் நெவர் தி அதர் வே. நான் பாராதைராய்டே பார்க்குறேன்னா அந்த டெஸ்ட் காமனாக பண்ணக்கூடாது. எக்ஸ்பென்சிவ் ஒரு பக்கம், தேவையும் இல்லைங்கிறது தான் போடும். எது தேவையில்லையோ அதை நம்ம பண்ண வேண்டாம். கால்சியம் பேசிக் லெவல்ஸ் நம்ம பார்த்துட்டா போடும். கால்சியம் ஹையாக இருக்கா, அப்போ பாராதைராய்டு இருக்கலாமான்னு அப்போ தான் சஸ்பெக்ட் பண்ண ஆரம்பிச்சுட்டு தென் யூ டூ அதர் கொஸ்டினிங். நான் உங்களை கேட்டேன் இல்லைங்களா, இப்போது டயர்டாக இருக்குது எந்துக்கிறது, அது எல்லாமே நம்ம பண்ணி முடிக்கணும். பண்ணி முடிச்சுட்டு அதுக்கப்புறம் வீட்டு கேட்கும். ஸோ பாராதைராய்டு மட்டும் இஸ் நாட் அ ஸ்ட்ரெயிட் ஃபார்வர்ட் ஆன் யுவர் ஃபேஸ் டயக்னோசிஸ்.
So over a decade itself, and technology in general. Well, in India, we are booming, and India is one of the best places doing it. Medical and they're trusting. It's always scriptless.
That's true.
As a surgeon, what are the techniques and the technology influence have you seen over the past decade?
Okay, there have been a lot. There have been a lot. Like the theaters that we use, the airflow that is maintained in the theaters is we call as laminar airflows. That is something that is there. We maintain the right temperatures within the theater so that the patient does not go into something called as hypothermia. We give patient warmers so that the patient maintains their core body temperature. Then we have the energy devices that we use during our surgery. So bleeding perisa agama paathuko, tissue dissection help. Then of course you have your endoscopic approaches, laparoscopic approaches. And last or the newest will be your robotic techniques as well. So the robots are there. Again, everything can be used for every surgery. The answer is no.
Okay.
சிலதுக்கு யூஸ் பண்ணலாம், எங்கே தேவையோ அதை யூஸ் பண்ணிக்கலாம், அவ்வளோ. The technology does not matter, but the person using the technology matters. So the surgeon will always be in vogue than the technology. Yes.
Operation theater will be, I mean, it's like ஒரு cricket ground மாதிரி இருக்கும். Front lights.
Yeah.
That the lights play the major role as well.
Yeah, definitely, yeah.
Like always, when I've been to the surgery, in Marathon, like these lights surround you.
Right.
And anesthesia also really good.
Yeah, definitely. And I'm giving only things from the surgical point of view. Yes, anesthesial developments are amazing. So without them, I don't think surgeries can happen. Yeah, definitely.
They said anesthesia.
Definitely.
Place also has been delayed right now for like paid phone surgery. Give them like
Yeah. Agreed.
like anesthesia is still given for them to have this numbness or pain-free.
Pain-free period. Yes. All that is
You like suggest all these treatments?
But depending on what surgery we are doing.
Okay.
So when you are breast surgery, so breast surgery, you're removing the entire breast, then we do give some sorts of anesthetic blocks that are helping the patient having less pain. But usually it's not a extremely painful surgery. But you can still give some blocks like interpectoral blocks, we say them. We can give that, and the patient is relatively better because they are able to have unrestricted movements of their shoulder after that. Because psychologically, as I told you, it's always peer pressure. You would have been already primed by your neighbor. அவ்வளோதான், சர்ஜரிலாம் பண்ண போக உன்னால் ஒரு மாதத்துக்கு கையே தூக்க முடியாதுன்னு all that. But the next day morning when the patient lifts their arm, then there is an entire stigma that's broken.
But there is difference.
There need not be. That's the point. There need not be actually. But we are already prepared for the stiffness from the neighbor. So no, I know I cannot lift. That's how you go about it. But actually after surgery, what we usually do is pre-operatively, we teach all the exercises to the patients on what they need to do. So we ask them to do it, say 3 days before the surgery in itself. So they get a hang of it. So on the day of surgery, we don't ask them to do much. The first day after the surgery, we ask them to start moving their leg. From the second day, they can do it full range. Because in a breast surgery, where you have to kneel not with the breast, but you have to remove the lymph nodes that we are talking about, those are in the axilla. So you encounter a lot of important nerves that surround, that are supplying the important muscles of your upper limbs movements. So we preserve all of them. We don't take them off unless it's a hugely radical surgery that hopefully should not be required for anyone. So when you do all that, the nerves are fine, your muscle is fine, then why don't you move it? That's the point we tell the patient. Everything is fine, then you have to move it. You start moving it and they're fine. It's usually possible.
I would like to talk about the post-op, doc.
Yeah.
Because how important after the breast organ surgery,
Uh-huh.
what are the post-op procedures or tests which are there 100% you have to do a lymph node test?
Okay, so a post-operative breast, since your question is in the yesteryear where I have to remove the breast. Okay.
Because I'm asking.
Yeah, I know.
since I have a personal.
I agree. So once the breast has been removed, with the lymph nodes, you have to subject that to a complete examination. You see whether you have removed the tumor in total and there has been adequate normal tissue around it that has been removed, which we call as technically margins. So once that is done, the surgical part is done. You don't have to go in and re-operate on that patient. Because the breast has been removed, there's nothing much that's going to be left behind. You don't have any margin that is first. So other than this, do you have to do any tests? The answer is no. Yalla. The surgical part is done. There's no more testing that you need to do. The rest is going to be a pathological testing that the pathologist is going to do for you. And then you're going to plan your further treatment. Anything that you need to do for the wound side is wound care, which of course the surgeon is going to tell you. He is going to say, okay, come to me once every so many days, depending on what type of suturing that they have applied. The drain care, sometimes we keep tubes that come out of the chest to remove all the excess or the bad water that is going to come out. So that care should be taught to the patient. Again, that will be done with every breast surgeon, not to worry. And once that is done, what we can tell them is to do adequate movements of the shoulder. I think that's very important. And the entire limb, say I've done a right breast surgeon, then the entire right upper limb should be moved. The precautions that we tell them after we have removed all the lymph nodes is to avoid any injuries to the distal parts. Like they are very keen on going home and cooking and all that. We tell them to do that. There's no restriction that they need to have. Just that they should prevent injuries because again, the lymph nodes have been removed. Some lymph nodes of the upper limb can go to the removed lymph nodes that we have. They can lead to some infection and some swelling, which we tend to avoid. It's not something that we will want as a surgeon. Yes, that's about it. Nothing great.
Does cooking and constant of heat exposure, like in women in general,
Okay.
does that lead to anything?
Anything is too big for me to answer.
Does that lead to
Cancer?
breast abnormality or like direct heat wave?
Not really. It's not so intense that this is going to happen. See, since you said anything, earlier we used to have soot-based cooking. I used to have wood fired and all that. They used to blow. So that soot might go into the lung and cause some lung infections or some changes that can occur, metaplastic changes, something to occur. Other than that, maybe they may have caused some cancer in the lung or something. But nothing that, I do cooking every day and I have developed cancer in the breast or in the thyroid per se. I don't think that's going to happen. I don't think that should be a reason to order in Swiggy and so on. Yeah.
Adrenal tumors.
Yeah.
Like, so even that, how does that impact? Does it start with the hormonal balance?
Yeah.
Or overall health?
Right. So adrenal tumors are tumors that are from the adrenal gland. They are usually picked while you scan the abdomen for some other reason. Why? Because most of them are non-functional. We say non-functional is there is a tumor that does not produce any hormone. That's what we call as non-functional. Usually. So we call this as an incidental finding. You're doing an ultrasound abdomen or say a CT scan of the abdomen for some other reason. You might have had some abdominal pain or you might have had some, say, a kidney stone for which you just want to screen yourself. And there you find an adrenal lesion. So that we call as an incidental finding. So there can be some which are picked incidentally, but they do have some hormonal imbalances that can have. What is the hormonal imbalance? Usually they overfunction. So I am expected to produce, say, 5 kgs of rice from my paddy field, from my rice field. I am producing 15 from the same area, which means I am overfunctioning, something like that. So my hormone value should be at X value. It is say 2X. It is 3X. Why? Because there is a swelling, which is again come out of your feedback system. saying, no, I will do my work. You don't control me. And it does that, and that could be a reason. So depending on what hormone is being produced in excess, the symptom is going to change. Like for example, your thyroid produces only thyroxine.
Yeah.
So there can be either a low thyroxine in your body or a high thyroxine in your body. Logical. Whereas with the adrenal, it's not the case. You have different zones doing different jobs. Adrenal is very important for our body to function. So
Adrenal is-
exactly. So you depending on what exactly is going to overproduce, it'll be like presenting in a different way.
Can stress and herbal lifestyles
Uh-huh.
trigger this adrenal or worsen any other conditions?
Oh, I agree. Yes, sir. Stress. Your stress hormone is called as cortisol. That is produced by this guy.
Okay.
So it's from the adrenal gland that this is going to be produced from. So in stress, are you thinking the adrenal is going to remain silent? No, it's going to be. Definitely is going to be affected. You don't have a choice with that. The sleep-wake cycle, all that plays a very important role in this adrenal homeostasis as well. No second thoughts with that. No second thoughts with that.
To be calm is a voice.
It's a good way. It's a good way, yes. Because any derangements in your body, there will be some role for the adrenal gland to address because any derangement is a stressful phenomenon. In fact, even a surgery is a stress.
There's a pressure they put you on like pre-op and
Mentally, yeah.
so that's
See, the stress begins with the labor. The doctor comes last. The stress begins with the labor. Yes. See.
So what are the first words like from this a very casual thing? What is your first word when you see someone on the patient pen and you go in for surgery? What is the first thing you say?
Okay, so I personally, as a practice, so I see through that I am there before the patient is actually either shifted into the theater
Okay.
or is subjected to anesthesia. So I tell them, personally from my point of view, tell them you'll be fine. You'll go in with good thoughts, you come out with good thoughts. We'll be speaking to you after the surgery. The same way you're speaking now. That's what I tell the patient. And I let them undergo the procedure, whatever is the procedure. Say if it's anesthesia or if they're yet to shift them, I tell them I've spoken to everyone outside as well. Your friends are waiting for you, or your relative is waiting for you, you'll be fine. So, of course, there can be a chance of untoward complications in any case for that matter. No one can be predicting that, but you should always be prepared for that. But that's again a rarity. You don't make rarity the rule, right? Exceptions can never be the rules. So that's fine.
While surgery, have you seen any complicated cases or like you were diagnosed for this?
Saho?
But as you open and perform surgery, like there may lesions or there may something else of it. How do you progress or improvise your surgery on that? Do you stop your surgery at that time? Do you improvise?
Right. So pre-operative planning is something that we do. So இந்த கேஸுக்கு இங்கே டிசீஸ் இருக்குது, இங்கெல்லாம் ஸ்ப்ரெட் ஆகிருக்கு, சர்ஜிக்கலாக போய்ட்டு இதெல்லாம் இருக்க போகிறோம். இதுதான் ஒரு ரஃப் எஸ்டிமேட். இதே நான் சொன்னதையே நீங்கள் எந்த ஆர்கனுக்கு வேணால் நீங்கள் பொறுத்தீங்க. எந்த ஆர்கன் பிரெஸ்ட்டுக்கு இதே பண்ணலாம், தைராய்டுக்கு இதே பண்ணலாம், பாராதைராய்டுக்கு இதே பண்ணலாம், அட்ரினலுக்கு இதே பண்ணலாம். ஸோ இது எதெல்லாம் வைட்டல் ஸ்ட்ரக்சர்ஸ் தட் ஐ கேனாட் டச் அப்படின்றத நமக்கு தெரியும். ஆனால் உள்ளே போய் பார்த்தீங்கன்னா அந்த வைட்டல் ஸ்ட்ரக்சரே இன்வால்வ்டு அப்படின்றது இருக்குன்னு வச்சுக்கோங்களேன். Then you have to take a decision. Of course, இதெல்லாம் ப்ரீ-ஆப்ரேட்டிவாக அந்த பேஷண்ட்டுக்கு ப்ரைம் பண்ணியிருக்கும். There's something called as informed consent that we get. ஸோ அவங்களுக்கு ப்ரைம் பண்ணியிருக்கும். பண்ணிவிட்டு தென் வாட் we do is we take a call. இதை எடுத்துட்டா நம்மளால் ரீகன்ஸ்ட்ரக்ட் பண்ண முடியும். ஸோ இட்ஸ் அ பிளட் வெசல்னு எடுத்துக்கோங்க. அதை என்னால் ரீகன்ஸ்ட்ரக்ட் பண்ண முடியும் அப்படின்னா then removing the cancer is very important. I cannot leave behind a lot of cancer and then expect you to treat that with other modalities. It will be very difficult. If surgery is the primary treatment option for that disease, then it should be addressed surgically completely. ஸோ ஒரு வெசலில் அப்படி பண்ண முடியும். ஆர் இப்போ நம்ம தைராய்டு எடுத்துக்கலாமே, தைராய்டில் லிம்ஃப் நோட்ஸ் நம்ம பார்க்குறோம். நம்ம உள்ளே போனால் ஒரே ஒரு லிம்ஃப் நோட் மட்டும் தான் நம்ம வெளில இது வரைக்கும் பார்த்துருக்கோம். இமேஜிங்லேயே அப்படி தான் இருக்கும். உள்ளே போனால் நிறையா இருக்குது அப்படின்னா அது எல்லாத்தையும் சேர்த்து எடுத்துகிட்டு அதை பண்ணும்போது அதுக்கான டெலிகேட் இம்பார்ட்டன்ட் ஸ்ட்ரக்சர்ஸ் இருக்கும். இந்த பிளட் வெசல் கோயிங் டு த பிரெயின் இருக்கும், பிரெயின்லேருந்து வர பிளட் வெசல் அங்கே தான் இருக்கும், நம்ம முக்கியமான மெட்டபாலிசம்க்கான வேகஸ் நர்வ் அங்கே தான் இருக்கும், நம்ம ஷோல்டர் ஆட்டுற நர்வ் அங்கே தான் இருக்கும். நிறைய ஸ்ட்ரக்சர்ஸ் காம்ப்ளெக்ஸாக இன்னொரு ஸ்பேஸ்க்குள்ளேயே இருக்கும். இந்த ஒரு இடத்துலேயே இது எல்லாமே இருக்க போகிறது. ஸோ இப்போ அதெல்லாத்தையும் நம்ம ப்ரிசர்வ் பண்ணி தான் ஆகணும். பண்ணி முடிச்சுட்டு எக்ஸ்ட்ராவாக சுற்றி இருக்கிற எல்லா லிம்ஃப் நோட்ஸ் அதை சுற்றி இருக்கிற வாட் எவர் இஸ் அரௌண்ட் இட் ஃபைபர் ஆஃப் ஃபேட்டி டிஷ்யூஸ்ன்னு சொல்லி எல்லாத்தையுமே கிளியர் பண்ணிட்டு தான் வரும். அப்சல்யூட்டாக பண்ணி தான்.
Improvise on it.
Yeah, you have to. Yeah. And again, you go into a surgery with a plan where I'm going to remove the thyroid and the nodes around it. Whereas I know this tumor is not a normal fellow. He can spread to the side also. எனக்கு தெரியும் அப்படின்னா அப்போ அதுக்கு நான் ப்ரிப்பேர்டாக போயிட்டு அதை அந்த லிம்ஃப் நோடு எதை நான் டவுட் படுறேனோ அதை தூக்கிட்டு அவனை வந்து பயாப்சிக்கு அனுப்பிடுவேன். இமீடியட் பயாப்சி, ஃப்ரோசன் செக்ஷன்னு சொல்லுவேன். அதை அனுப்பிட்டு அதில் கேன்சர் இருக்குன்னு வந்துருச்சுன்னா தென் ஐ ஹேவ் டு டூ அ கம்ப்ளீட் கிளியரன்ஸ் ஆஃப் தட். இப்போ நான் சொன்னேன் இல்லைங்களா, எல்லாத்தையும் எடுக்கணும் இவங்களாம் பிரச்சனை, அந்த கம்ப்ளீட் கிளியரன்ஸ் பண்ணி தான் ஆகும் அந்த மாதிரி. ஸோ தேர் வில் பி சம் இன்ஸ்டன்சஸ் வித் parathyroid இட்ஸ் ஈவன் மோர் ட்ரிக்கி. ஐ டோல்ட் யூ parathyroids ஆர் ஆல்வேஸ் ட்ரிக்கி. நீங்கள் எங்கே இருக்குன்னு நினச்சி அங்கே போகிறீங்களோ அந்த இடத்துல அவன் இருக்க தேவையில்லை, இங்கே எங்கேன்னு இருப்பான். ஸோ நீங்கள் நெக்கை ஃபுல்லாக எக்ஸ்ப்ளோர் பண்ணி பார்த்துட்டு எடுக்கிறது தான் பெட்டர். ஸோ அந்த மாதிரி சேலஞ்சஸ் இருக்கும். தென் யூ யூஸ் யுவர் அட்ஜங்க்ஸ். நான் உள்ளே போய்ட்டு அல்ட்ராசவுண்ட் வச்சு பார்க்கணும், அந்த நிறைய விஷயங்கள் இருக்கும்.
So I think so. This is a frequent question.
Yeah.
Every patient asks.
Yeah.
ஒன்றில் உடம்புறீங்க வாய்ஸ் போயிடுமா?
சூப்பர். எக்ஸாக்ட்லி, வெரி குட். இப்போ என்னென்னா, ஸோ வாய்ஸு எசென்ஷியல் எல்லாருக்குமே. பேசி ஆகணும் டு கம்யூனிகேட். சில பேருக்கு பேசுகிறது தான் அவங்க ஆக்கியூபேஷனாக கூட இருக்கும். ஸோ ஆல் த மோர் லைக் தே கேன் பி அ கர்நாடிக் சிங்கர், தே கேன் பி அ ரேடியோ ஜாக்கி, தே கேன் பி அ டீச்சர். ஸோ அது ஆல் தட் இஸ் வெரி 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 எசென்ஷியல். ஸோ நம்ம அவங்களுக்கு என்ன பண்ண போகிறோம் அப்படின்னு பார்த்தீங்கன்னா, இப்போ நீங்கள் தான் என்கிட்ட வரீங்க, நீங்கள் இந்த வாய்ஸில் தான் என்கிட்ட பேசிகிட்டு இருக்கீங்க. போன மாதம் உங்கள் வாய்ஸ் எப்படி இருந்ததுன்னு கேட்குறேன், இப்படி தான் இருந்தது. போன வருஷம் எப்படி இருந்து கேட்குறேன், இப்படி தான் இருந்தது நீங்கள் சொல்கிறீங்க எடுத்துக்கோங்களேன். ஸோ இப்போ இந்த ஸ்வெல்லிங் உங்கள் வாய்ஸை பெருசாக மாற்றலைன்னு நான் எடுத்துக்கலாம். ஓகேங்களா? இது நான் உங்களுக்கு கிட்ட கேட்குற கேள்வி வழியாக ஒரு டெஸ்ட் ஒன்று இருக்குது, வீடியோ லெரிங்கோஸ்கோப்புன்னு சொல்லுவோம். உங்கள் வோக்கல் கார்ட்ஸ் எப்படி மூவ் ஆகுதுன்னு சொல்லிட்டு நம்ம பார்க்கலாம். அதை நம்ம வாய் வழியாக பார்த்துட்டு ஒரு லோக்கல் கார்ட்ஸ் எப்படி விஷுவலாக எப்படி இருக்குன்னு பார்த்துக்கேன். ஈவன் திஸ் இஸ் நார்மல். இந்த சான்சஸ் ஆஃப் த ஸ்வெல்லிங் என்ன சர்ஜிக்கல் சர்ப்ரைஸாக நீங்கள் கேட்குறதா, உள்ளே போய் பார்த்தா நர்வ் இன்வால்வ்டு, இந்த கேன்சர் மாதிரி இருக்குது அதை பாரு, அப்படி வரதுக்கான சான்ஸ் ரொம்ப கம்மி. ஸோ தான் ப்ரிப்பேர்டட்னஸ் தான் சொன்னேன். அந்த சர்ஜிக்கல் பிளானிங் சொல்கிறேன் பார்த்தீங்களா, அந்த ப்ரிப்பேர்டட்னஸ் உள்ளே போகிறேன், இந்த கார்ட்ஸும் நார்மலாக இருக்குது, வாய்ஸும் நார்மலாக இருக்குன்ற பட்சத்தில் யூஸ்வலாக இன்வால்வ்டாக இருக்கிறதுக்கான வாய்ப்பு கம்மி. ஸோ அதுக்கேற்ற மாதிரி நம்ம ப்ரிகாஷன்ஸ் எடுத்துக்குவோம். வேறஸ் நீங்கள் என்கிட்ட வரும்போதே உங்கள் வாய்ஸ் சார் 1 month நான் இப்படி தான் இருக்கேன் அப்படின்னு நீங்கள் வரீங்கன்னா தென் அப்போ அந்த வீடியோவில் ஐ எம் எக்ஸ்பெக்டிங் சம் சேஞ்சஸ். இந்த டெஸ்ட் எடுக்கும்போது ஆப்ரேஷனுக்கு முன்னாடியே இதெல்லாம் அட் த சேம் டைம் இன்ட்ரோ ஆப்ரேட்டிவாக ஐ ஷுட் சஸ்பெக்ட் இது எதாவது இன்வால்வாக இருக்கலாமா. இங்கே நர்வ்ஸ் எல்லாம் உங்களோட ப்ரீ ஆப்ரேட்டிவ் இமேஜிங்கில் உங்களால் கரெக்டாக பார்க்கவே முடியாது. இப்போ ஒரு லிம்ஃப் நோட் நீங்கள் பார்த்துருவீங்க, உங்கள் கேன்சர் கட்டியை நீங்கள் பார்த்துருவீங்க, இந்த மைக்ரோஸ்கோபிக் ஸ்ப்ரெட்ஸ் எல்லாம் உங்களுக்கு சொல்ல முடியும். ஸோ அந்த ப்ரிப்பேர்னஸ். பட் ஆஸ் அன் தைராய்டு ஸ்பெஷலிஸ்ட் சர்ஜன் we expect the voice to remain as what it is if it is not in.
But there are like possibilities where they have a temporary.
Exactly. Very good.
situation.
Temporaries can occur because there will be people who are present with a very large neck swelling. It's actually compressing the nerve and the nerve is edematous. நீங்கள் போய் எடுத்துடுவீங்க, பட் அந்த நர்வை சுற்றி இருக்கிற வீக்கும் நார்மலானதாக அதை ஃபுல்லாக அதோட வேலை செய்ய முடியும். ஸோ அப்போ சொல்லிவிடுவோம் உங்களுக்கு 6 weeks டைம் கூட ஆகலாம் ஃபுல் ரிகவரி வரத்துக்கு அப்படின்னு சொல்லி. 6 weeks ஆகலாம், சில பேர் 6 months ஆகலாம். ஸோ we do something called as voice therapy, speech training and all that. Well, that can be possible.
Post-op, there is a lot of things.
Definitely. இது எல்லாமே அந்த இண்டிவிஜுவல் பேசிஸ் தான். இப்போ நான் ஒரு பிளாங்கெட்டாக ஒரு விஷயம் சொல்ல முடியும். பிளாங்கெட்டாக என்ன சொல்லலாம்னா மோஸ்ட் பீப்புள் வாய்ஸ் ஒன் சேஞ்ச். அந்த மோஸ்ட் நான் 100% நம்மளால் வித் நேச்சர் there's nothing 100% here.
Probably now I could go like general well-being. Let's go as a surgeon, as a doctor as well.
Yeah.
How does social media impact a person's body image or contributes or not to stress related issues? And we see thyroid, also parathyroid does involve stress. High stressful jobs.
Parathyroid stress, not really. But adrenal and thyroid, I will agree.
Yeah. Like stress and factor, like high stress jobs, as you say, teachers or pilots, the adrenal, which is their pushes it, they're firefighters, workers. How does this impact, like how does one take care of their own body, like as a teacher? Because they have to be screaming in distance, have a mega point. Those things, for a teacher's perspective, or people in high stress level jobs.
Okay.
As a surgeon, what do you would want them to do? Like take a break or or not talk more.
Right. Okay. So some voice rest will help, and I would recommend proper diet and proper sleep. If these two can be possible, most of things will be under control. And again, you always try to have control over your emotions. There can be times when, as you said, like a teacher might be shouting at the student, shouting at the class per se, not the student, shouting at the class per se, and all that. You don't let your emotion into that. I think that should be enough. That's how I'll see it as remain slightly jovial, or take a break. Even if it's just a 2-minute break, that's still okay.
We say don't linger on that.
Yeah.
Like, if you shout, scream, leave it at that.
Done. That's done. Yeah. You don't want to carry it forward. Carrying it forward might not be the right way.
It might lead to something like all down the lake.
You keep thinking, and we always overthink. So,
with the stigma about surrounding cancer and, as I said, the breast as well, thyroid health. As a surgeon or perspective, or like from your close family or your friends,
yes.
how do you give a word of advice to them?
Okay. So with breast, as I told you, at least your immediate friend circle or family, like after this talk that we are done with, you can recommend your mother's siblings. You can tell them screening is essential. That's all. You can tell your daughter, once she is 30 plus, screening is essential. You can tell your sister screening is essential. For breast, screening is very important, because when you pick it early, the amount of cure rate is unimaginable. So whatever you're seeing in movies and serials, they don't go hand in glove here. You have about 90 to 95 or even 98% you can cure. They have a 10-year survival of 98%. That's unbelievable numbers. So the early detection is key for any disease per se, especially for malignancy. For any cancer, early detection will be key. So how do you do that? With the thyroid, again, as I told you, an ultrasound will help. Just a periodic ultrasound. It need not be that you have a swelling. If you have a swelling, then I would recommend it for sure. So screening is when you're actually doing something for something that's non-existent. So with breast and thyroid, that should happen. Yes.
Have you seen the other thing, more cases in the rural areas than the urban life? There are difference. There are more patients coming in from the rural side. Is there a lack of awareness?
Okay, with thyroid per se, they might come with a long-standing thyroid swelling, which means they have the swelling in the neck for like many years. It won't bother them. As I told you, it's just a swelling. Unless it's going to cause a compression, or it's like I'm not able to do my day-to-day activities. So unless it's going to harm their day-to-day activities, I don't think they are bothered about that. But that's one thing. So they predominantly have larger glands. Again, this is not something that I commonly see. It's just a potential possibility. And there might be people who detect their breast lumps late. And they detect the breast lump incidentally. Like I'll tell you one situation where I faced. So I was at the hospital, ஒரு அம்மா வராங்க. அவங்களுக்கு எப்படியும் ஒரு 50 வயசு இருக்கும். 50-52 இருக்கும்னு நினைக்கிறேன். எக்ஸாக்டாக ஞாபகம் இல்லைனா கூட 50-52 வயசு இருக்கும். அவங்க என்ன சொல்கிறாங்க, சார் எனக்கு வீட்டில் தோட்டத்தில் நாங்கள் தென்னை மரம் வச்சுருக்கோம். தென்னை மரம் வச்சு அந்த தென்னை மரம் பறிச்சிட்டு இருந்தார். எங்கள் ஹஸ்பண்ட் தான் பறிச்சிட்டு இருந்தார். அப்போ நான் நவுறத்துக்குள்ளே என் மேலே பட்டுடுச்சு. என் பிரெஸ்ட் மேலேயே வந்து பட்டுடுச்சு. அப்போலேருந்து எனக்கு ஒரு புண்ணான மாதிரி இருக்குது. இட்ஸ் ஜஸ்ட் அ ட்ராமேட்டிக் இன்ஜுரி. ஸோ ஐம் திங்கிங் பெஸ்ட் பெயின் ஏதாவது இருக்கும் அப்படின்னு சொல்லிட்டு தான் நான் உள்ளே போய் பார்க்குறேன். எக்ஸாமினேஷன் ரூமுக்கு போகிறேன். என் ஸ்டாஃபை கூட கூட்டிகிட்டு போயிட்டு எக்ஸாமின் பண்ணுறேன். அவங்க அப்போ வந்து எக்ஸ்போஸ் பண்ணுறாங்க. பார்த்தா there is a huge mass and the skin has ulcerated.
Visibly outside.
Out. அவ்வளோ வந்துடு. அங்கே ஒரு புண்ணே வந்துடுச்சு. ஸோ அவங்க அடிப்பட்டதுக்கப்புறம் தான் அது ஒரு புல்லாகவே பார்க்குறாங்க. அதுவும் பாசிபிள். திஸ் இஸ் அ ப்ராப்பர் வில்லேஜ் லேடி. ஒரு எக்ஸ்பீரியன்ஸை சொல்லணும். அந்த ஒரு எக்ஸ்பீரியன்ஸ் சொல்லாமல் தவிர இதுதான் எல்லா வில்லேஜ் லேடிஸும் இப்படி தான் வராங்கன்னு நான் சொல்ல வரல. பட் இப்படியும் நடந்திருக்குன்னு சொல்ல வரேன். ஸோ அவ்வளோ லேட்டாக வருவாங்க. அண்ட் இதை அவங்க வந்து ஒரு பொருள் அவங்க இந்த அடிப்பட்டதுக்கப்புறம் தான் இந்த புண்ணு ஆயிருக்குன்னு நினச்சிட்டு இருக்காங்க. அடிப்பட்ட 2 வாரம் இருக்குன்னு எடுத்துக்கோங்களேன். அப்போ தான் இதை விஷயமே நினச்சிட்டு வராங்க. ஸோ delayed diagnosis can occur because of probably this lack of awareness is what I will put it to, and not just rural. If the awareness is not there in urban, they don't have in the same way. So,
That's true, as you said, even for my cases or for my mother as well. It went very unnotified. When she had like a heat point,
yeah,
and which that amounted to a really big thing.
exactly.
So
என்னன்னா we try to over diagnose ourselves. இப்போது எனக்கு ஒரு கத்தி வந்துருக்குன்னு வச்சுக்கோங்களேன், நான் நினைப்பேன் நம்ம எல்லா மெடிக்கல் டைமும் இதுவாக தான் இருக்கும், நம்மளை சாட்டிஸ்ஃபை பண்ணிடுறோம் ஏதாவது ஒன்று சொல்லிட்டு. இட் கேன் பி சம்திங் எல்ஸ் ஆல்சோ. நீங்கள் சொல்கிற அந்த ஹீட் பாயில் கேன் பி சம்திங் கால்ட் அஸ் பிரெஸ்ட்டில் பொறுத்த வரைக்கும் சேட்டலைட் நாடியூல்னு சொல்லுவோம். உள்ள கட்டி இருக்குது, அவன் கண்ணுக்கு தெரியாமல் ஸ்ப்ரெட் ஆகி ஸ்கின்னில் ஒரு பாயில் மாதிரி வருது. ஸோ அதுவே கொஞ்சம் அட்வான்ஸ்டு ஸ்டேஜ் தான் பெஸ்ட்டை பொறுத்த வரைக்கும், அப்படி சொல்ல வர. ஸோ அது அப்படி தான். ஸோ நம்மளே இல்லை இது பாயிலாக தான் இருக்கும், க்ரீம் போட்டு பார்ப்போம், அந்த மாதிரி நம்மளே பண்ணுவோம், ஏதாவது பண்ணுவோம்.
and we did that. Then after that, one person said like, give it a try, go for now,
Good.
go check it. And after
Then they diagnosed it. Yeah.
it was like that.
Yes.
As you said, went into a lot of procedures.
Correct.
Post-op cameras, we should have done things, but the lymph node actually developed in a year after post-op, which they said it was a post-op swelling.
Okay.
And it should wear off. Then after the 6th month of PET, then the doctor realized that it wasn't a swell. The lymph node was still active below her neck. Okay, so that caused went into cases where it's way far than our hands.
Right.
So that's what I wanted to know the most care after post-op. Like you shouldn't lift, like once you're done, you think it's going to be cancer-free, but then it has to be taken care of, their nodes and those things.
Okay. So, good point. So, if I say you are cancer-free after a surgery, might be difficult to see. Because there can be still microscopic spread that I can't see. So, you will be cancer-free after completion of all modalities of treatment. There can be some who require tablets, there can be some who require chemotherapy, some that may require even targeted therapy, depending on, I told you, right, the tumor biology. Everything matters in the tumor biology. So once the tumor biology is known and you have treated that with the best armamentarium, with all your armamentarium, you hit it across, and then I can probably say you'll be cancer-free. So immediately after surgery, you're gross cancer-free. Anything that I could say, I will remove. Okay. That's a guarantee that I can do. I cannot say you're cancer-free for sure. So there's always a potential for microscopic spread. Yeah.
Microplastics, pollution, anything concerned to water, any lace pan, or something. They say it. I mean, the shampoo cases also we have seen recently, which has very micronutrients is what they use, which causes cancer.
Okay. That's
From a plastic bag, do you think is dangerous or any aerated things? Is it true or is it like a myth?
myth, truth, I don't know where it exactly stands. But does it cause malignancy of the thyroid or the breast? The answer will be no. I think I can restrict my discussion to that. Okay. Because it may be a potential factor elsewhere. Because the preservatives that are being used may be carcinogenic in some animal models. Whether that has translated into human life, I don't know yet. So that could be a part of some ongoing research, whether this is actually being related to actually causing this. That's something that we have to consider. But we cannot put the blame on him yet. Like how you were saying, right? Why me? Why cancer and stuff? Smoking, alcohol. So smoking and alcohol have been proven to be independent factors to have caused some cancer. That's why this terminology is being used even by a layman like you now. You are not a medical person. Still, you are able to use that, which means in some part it has been proven and that has been into our ears through some medium or the other that it can cause. Like a cigarette box has this tobacco is injurious and they have these ulcers in the mouth. It's proven to cause cancer in the oral cavity. So you cannot say cancer is caused by smoking. That's too big. Some cancers can be caused by smoking. And those cancers are some regions that are highly reactive to this. Like say for example, I smoke and I developed breast CA. I smoke, I developed brain tumor. I smoke, I developed a prostate CA. All that are vague statements. We cannot say that for sure. Whereas with an oral cavity, with an upper aerodigestive tract, upper esophageal, you can say that. It's been proven that smoking is a risk factor to cause this. It increases the relative risk by some number, not the exact number that I'll be able to quote, but definitely it is going to increase. So that plays a role. I cannot just generalize and say I drank alcohol, I developed cancer. Alcohol can cause cancer in every part of the body? I don't think so. Similarly, smoking in every part of the body? I don't think so. That's how I will see it as. Yeah.
Probably something you magically think that I would expect. Will there be a treatment or any kind of like injection or any kind of what do you say preventive methods?
Okay.
But will there be something that we can say like if someone has a cancer, this treatment done around? Will there other days coming in where there will be for any type of cancer? Will there be a treatment and keep it in death happy? Are we there? Is there a science study or research?
Okay, in case your question is before the patient has developed cancer, or is it if they have cancer?
Even after, or like both ways as well.
Okay, say for example, you have come to me with the thyroid cancer. Any patient has come to me with the thyroid cancer. I knock thyroid off. I do a surgical thyroidectomy. And if the lymph nodes are involved, I remove everything of them. All gross disease I have removed. My treatment is complete. But I still have a chance of microscopic spread. So my biopsy report is essential for me. And then we do, depending on what type of cancer it is, we do a whole body scan with an iodine, a radioactive iodine drug. If there is a spread anywhere else in the body, we do some blood tests as well. If there is spread anywhere else in the body, then we ask them to take a higher quantity of that iodine to go act there and cure it. Instead of going and surgically removing all of them, you can go, let's say in the lungs. You don't want to touch the lungs unnecessarily, right? You can go, so you can give this iodine therapy and it's done. And your life expectancy, if there is no residual tumor or anything, it's a predominantly low-grade tumor, for example. Okay, forget the lung part also. It is not spread anywhere. Okay. It has been in the neck, which I have surgically removed, you are fine. You just put you on thyroid tablet lifelong. The life expectancy is as good as your fate. So I think we have reached that point in most malignancies. I don't know if I can call it most, but a good number of malignancies per se. Your treatment armamentarium that you have can keep you disease free for a good period of time and improve your overall survival as well. I don't think I'll have doubts with that. Yes. But is there a vaccine that I can put and...
Or to the next question.
Is there a vaccine that I can put and say, okay, no, I won't develop cancer anywhere? No, that's too big a ask. You have like, I don't know,
Getting that?
10 to the power of 23 cells in your body and you want one vaccine to do magic? Okay, I don't think that's going to happen. So, and in case that has to happen, as I told you, right, the body has its own defense mechanisms. So we have any cell, even every cell division is monitored. Every single cell's division is monitored. It goes awry, that cell is dead. That's how the body works. I think that's a very good defense mechanism in itself. You give a vaccine from outside and that alters this defense mechanism, saying, okay, I will take care. And it does not do its job. Then you don't have your own defense. So now you have the defense that you have from outside. That's going to help you. So that will be pretty tricky. I don't think I'll subject myself to this.
The miraculous.
Yeah.
Or
I don't think I'll expect myself to,
face the
believe that. Yeah. That will be difficult. Right? So there will be people who come and say, no, actually I did this and I won't did it. Might not be true. That could be an industry gimmick. It could be an industry. I give you one vaccine, I'm curing you of all diseases in your body. That's
a business.
That's the height of expectancy. But yeah.
If there was something like probably, it would be great. With something like vaccines are something which like polio.
Yeah, it's up for you. Definitely, yes.
Like HIV is now where you can live for like 10 to 15.
HIV, I don't think you have a vaccine for HIV yet.
I'm saying there are treatments.
Yeah, exactly.
For long years.
Exactly, that's what I'm
We
saying.
didn't have those things.
Logical. So similarly, for in any malignancy, they will have their own set of treatments. Just that you need to be at the right place at the right time. And of course, financial affordability also plays a role. None of everything that we have spoken about is going to be absolutely free or will be expensive. Some of them will be as I told you, the targeted therapies. Well, that is going to be expensive. The chemotherapies, of course, are affordable to most right now because they have been there for a longer time. The target therapies are very new. They're in vogue for the past few decades only. Chemotherapy has been done for much longer, like probably even 50 years or something. But they will be cheaper now, logical. Like with any drug that's newly
More the cases, more the treatments are cheaper, or more the cases, the treatments are more expensive.
Okay, so I have a case of, say, a CA breast. There are 20 cases that we have seen. I'm speaking, this is the first time CA breast has ever been diagnosed. Treatment is going to be expensive because I'm trying a newer drug in a lab, confirming that is going to be effective, and I'm bringing it. So there is so much of testing that I have done to bring it into the market, say for example. So when there are only 20 cases, it's going to be expensive. Now I have done this over 50 years. Now I know it is time tested. I know it is going to work. My production cost, everything is going to be on the lower side. Then it becomes cheaper. That's how I'll think of it. So that's why I'm saying chemotherapy is slightly more affordable than a targeted therapy. That's how it will be. Logical. Just logical. You're going more elite with targeted therapy because it's recently in research. It's come into the market now. That's how it will work. I think this part probably we can avoid in the video, I think. But yeah. This is it. No, this bit alone, like the cost part, I think we can avoid this part of that conversation.
Going down to the last question.
Yeah.
And
Any advice to your referring doctors who are want to get into your field, who are studying education?
Yes.
Any words of encouragement?
Great. I think definitely. So you have to do your master's in general surgery, and then you'll do a super specialization in endocrine and breast surgery. That's an MCH course that we can do. It's a lovely field. I am loving it. So more the merrier. That's good that anyone who wants to take this up can definitely take it up. No second thoughts. The scope is always there. Not to worry.